Hi, and welcome to Dr. Brainwaves. I'm Dr. Rena Azar, and I'm going to talk about various versions of hysterectomies today. We're just going to do a brief overview. So this is how we do a total abdominal hysterectomy. You lie down flat on the bed, and we do an abdominal approach with an incision here. That incision in the front wall of the abdomen will be vertical or horizontal. Generally vertical if it's going to be a difficult surgery, if perhaps the uterus is quite large. Sometimes when an individual is a little bit large, we have to make a larger incision so that we have easy visibility. We can get in and get things out. This type of surgery has the downside of needing a little bit longer healing because the incision is a little bit larger than what we use for a laparoscopic or robotic approach. And therefore, we don't want you to develop a hernia if that front wall gets weakened by excessive lifting, pulling, tugging, or activity levels that are very strenuous. So we generally keep people off of strenuous activity for a little longer with this type of surgery. Advantages to this surgery is that you don't have to be put under general anesthesia. We can do a numbing, which is a spinal anesthesia from the waist down. That's something we can't do in the other types of surgery that we're going to go over today. So you could do a local or regional anesthesia with a spinal like we give people for childbirth, and the person can stay awake and usually happily sedated so that they're not necessarily having discussions with the OR staff. They're just relaxed, comfortable, not really aware what's going on. But in certain situations, it's safer than putting somebody to sleep. Sometimes people are apprehensive about anesthesia. There are some rare medical conditions that make anesthesia administration via a mask actually unsafe. There are certain health conditions such as underlying lung disease that might make us want to do a spinal. So that's an advantage to a total abdominal hysterectomy. Total abdominal hysterectomy allows us to get our hands in there and actually feel what's going on. There are certain circumstances, particularly with tumors or infected tissue, where getting your hands in there and handling stuff gently is a little bit safer in terms of avoiding some kind of perforation or puncturing of tissue, which you can have with a hands-on situation versus a laparoscopic or robotic surgery where you lose your tactile feedback. You can't actually feel very well what you're pulling and tugging on. So that's a total abdominal hysterectomy. And this picture is going to cover three other versions: a total vaginal, a total laparoscopic, and a laparoscopic assisted vaginal hysterectomy. In this situation, the patient's lying on the bed. Generally, the legs will be up in the air in stirrups. And to do a total vaginal hysterectomy, we just go in down from the vagina and we make an incision around the top of the vaginal cuff, pull the uterus out, kind of like delivering a baby, and close that top of the cuff up. Downside to that particular type of surgery, we can't really see if there's anything going on in the abdomen. So if you had endometriosis or scar tissue, we would not likely know it. That would be an unsafe approach for somebody that we know has had previous abdominal surgeries and or is likely to have endometriosis or scar tissue inside, because it could compromise that surgery if that scar tissue or endometriosis is down low where we're trying to get in to take the uterus out. But nonetheless, that is a total vaginal hysterectomy. Total laparoscopic hysterectomy is the opposite, and we go up top with laparoscopic instruments. These incisions for this type of procedure are anywhere from 1 centimeter to 0.5 centimeter. Usually the camera is in a 5 millimeter or 0.5 centimeter, and the other ones, depending on what we're removing, may be a larger incision. For total laparoscopic hysterectomy, you'll have to have a little bit of a larger incision so that we can take the uterus out. We cut around the cervix, which is the lower part of the uterus at the top of the vagina, and we actually just take out the whole blood supply on either side of the uterus and down low. Then we take the uterus out the front wall of the abdomen, and we're not doing anything vaginally. Usually the uterus will have to be put into a sac and or morcellated or cut into little pieces so we can pull it out. So that's a total laparoscopic hysterectomy. A laparoscopic assisted vaginal hysterectomy is one where we put a camera in and a couple little instruments. Sometimes we have all these. When I do mine, I usually do all 5 millimeter or 0.5 centimeter incisions. But if you're taking out something that's a little larger, you want a little better visualization, you might use 1 centimeter incision. And we go in, take the blood supply out, clean up scar tissue or endometriosis if we encounter that, and take the uterus out from down below like you're having a baby. And the perk to that is you don't have to have an abdominal incision. and yet you get to see everything that's going on in the abdominal cavity, which is a good procedure for people who've got unexplained pain, where we might want to investigate whether you have scar tissue or endometriosis. If we look at robotic surgery, robotic surgeons use centimeter incisions, 8 millimeters to 10 millimeters, which is about a centimeter. There's a camera site, and then there are 2 other port sites. This robotic hysterectomy is not done with the surgeon at the bedside. They're actually sitting at something called a console in the same room, looking at some viewing goggles, and then operating these 2 little hand-like devices down at the end of the laparoscopic tick. So one advantage to this is that we don't have to do so much movement of these larger trocars or pulls through the abdominal wall, which can be a little cumbersome in somebody maybe who's a little thicker on the anterior abdominal wall, because we have some additional movement. We have not just the movement of the stick or pull that is holding the surgical instrument, but we also have some additional movement inside it with a hand-like device. So you can do finer dissections. This particular surgery is really, really key in oncologic surgeries. This is something that requires a fine dissection, extensive takedown of scar tissue or removal of lymph nodes are all procedures that should have robotic surgery, because we can get in and do finer work through small incisions. So that is robotic assisted hysterectomy. And those are the different versions of hysterectomy. It will be up to your doctor. There are a number of factors that make us consider what type of hysterectomy. One is your personal issues. If you have underlying medical conditions, your habitus, have you had multiple previous surgeries? What are we expecting is going on? What have we seen with imaging? And then there's also the kind of training and comfort level that your physician has. Generally, physicians like to keep a lot of tools in their tool belt so that they have lots of different options for the approach to hysterectomy. So hopefully that was helpful for you as an overview of different types of hysterectomy. I want to go over one more thing, and that is the difference between a total hysterectomy and a partial hysterectomy. That's a little bit of layman's terms. Generally, a hysterectomy is removal of the uterus, and that would include the uterus with its cervix, which is the lower part of the uterus that opens into the vaginal area. And the tubes are also part of the uterus. So you want to know, is your doctor removing your uterus with the cervix or without the cervix? Is your doctor removing the ovaries and the tubes? If you have a hysterectomy, your doctor should remove your tubes. There's no reason to keep tubes. They don't produce any hormones. They are the source, now we know, of some very bad cancers. So if you're having somebody go in your abdominal cavity, whether you keep your ovaries or not, the tubes should be taken out. One other consideration is that oftentimes when people have total laparoscopic hysterectomies, the uterus will be taken out and at the top level and leave a little bit of the cervix in. Please remember that the cervix is the hot spot for HPV-related cancers. So there's an area in there called the transition zone, which is a hot spot where cancer is more likely to occur and more likely to be aggressive. So if you leave your cervix in, you're going to need to be aware of that and be mindful of the need for pap smears and close follow-up. If you want to remove that risk, having your cervix out is a good idea in general. There's also one other factor that I would comment on, and that is that the uterus has multiple supports to it. In other words, there are many ligaments being the firm tendon-like areas that we have in our wrist or our Achilles tendon. Ligaments support the uterus. We have cardinal ligaments, uterosacral ligaments, broad ligaments, and round ligaments. Of those, the most supportive are the cardinal ligaments and the uterosacral ligaments. So you want to remind and make sure that your doctor reattaches ligaments to the top of the vagina. If you take the uterus out and you sever all of its ligaments, then you need to resuspend the top of the vagina to the ligaments that were previously holding the uterus up. My strong preference is to have a permanent suture in there. I use Ethibond every time when I reattach the ligaments that used to hold the uterus up to the vagina to hold the vagina up, so you don't have to come back in later and do a sacrocolpopexy to put that vaginal apex or the top of the vagina back in where it should be. So that is hopefully a helpful rundown of hysterectomies for you.